Hi, guys, and welcome to another episode of Cath Lab Chat. I am your host, Jeremy Miller, and this week we have an exciting podcast guest. We have Jason Chan. He's the owner and operator of ECMO PRN, which is a company he started that helps transport and initiate ECMO and extracorporeal membrane oxygenation, which we talk about. We really explain it from kind of end to end. But just as a preclude, we do kind of leave out some of the patient advantages. He does cover it, but I kind of sound a little, jaded when I don't go over the moon about it because I think the advantages are pretty clear. And Jason does a really good job explaining things. But I think the thing that excited me most about it was that it makes sense for the hospital and it makes sense for the patients. And it's taking an old technology that's been around for a long time. ECMO has been around, but now ECMO's coming in a much smaller package, and which gives you this mobile option to kind of initiate ECMO at one site and transport them to another site, which then means a lot for your patients. It means they have a lot more options, and there's a lot more time instilled in this whole situation. You go from a very urgent, emergent, life-threatening event to, if you're able to get them on ECMO and it works for them, you can really change somebody's life. And I think that we have seen that at my facility, where we've had a couple of people that we would have been good candidates had we had the program up and running. So we've been getting education on it, and I can tell you personally, I've seen multiple patients where I think they would have been great candidates, especially on the younger side, where we just don't offer much more of LVAD support outside of an Impella. And there are a lot of places that don't even have that. I think it's pretty common, but there are some places that don't have it. Whereas this ECMO program that he has it's really special, and I see it taking off nationwide. But he's just kind of opening up a local Bay Area situation, and I think if you listen to what he has to say, it's really interesting, and it's interesting from an innovation standpoint to kind of understand, how and why now it's different and versus 10 years ago or 5 years ago, because this technology has been around. They've been doing, heart lung bypass and perfusion equipment for years. And now we've got kind of a mini version that's much more mobile, and the options that affords patients, which is huge, as well as, just hearing a story of somebody who was, he was an EMT, then he went on to be, a perfusion tech, and then he went to nursing school, and then he got out of nursing school, and he rose up to be administrator, and his passion was in kind of running his own show, and he had a lot of experience in perfusion before, so he kind of put all those things together, and now he's working for himself, and he's doing something really exciting, and I couldn't be happier for him. I love to share these stories where people have a chance to kind of spread their wings and go out on their own and really find a way to make their own in this market, so that we're not always dependent on hospitals. They're great, but I just love to see people kind of spread their wings and do their own thing. And I think this is going to be on fire. I think we'll eventually see something like him or him himself go nationwide. I think that there's a lot of opportunities with this technology, and the way he's implemented it is it's just genius. So look forward to this podcast, and I hope you enjoy it. And we have one other big announcement. So a little while ago, the folks over at the Scanner magazine reached out about the podcast, and they're going to do segments in the Scanner magazine about interesting things that techs are doing. And they talked to me about Cath Lab Chat. So Cath Lab Chat is going to be in Scanner magazine, either the October-November issue or the December-January issue. I will update you as soon as I know, but I'm thinking it's going to be in the October-November issue. And when that comes out, I'll let everybody know, and I'll flash it up on the website. So if you guys have any questions about ECMO, or you'd like to see other topics on the podcast, just please let me know at jeremy@cathlabchat.com, or cathlabchat@gmail.com is probably the better one. That'll get me much faster. Or hit me up on the Facebook page and let me know what your thoughts are about the podcast. I've had a ton of people come join the podcast online, and it's looking great. So thanks, guys, and I kind of a little rough start getting into the podcast, but thanks for listening, and here's Jason. Well, welcome to the show, Jason, and glad to have you on the podcast. So you're with ECMO PRN. You are the owner and operator and entrepreneur. So, so let's jump into the easiest question. Everybody's talking about ECMO, at least around the country, for different labs. It's going into different places. What's ECMO?
Sure. So to put it simply, ECMO is the removal of deoxygenated blood from the body, providing adequate gas exchange, O2 and CO2, and then pumping that oxygenated blood back into the body. But I'm going to give you a slightly different definition of what ECMO is, and I'll give you the definition that I talk to families about because I get asked that question pretty often by family members. And so the way I explain what ECMO is it's like calling a timeout, right? We're getting ready for the NFL season, we're ready for football. And so during football, if a team calls a timeout, what happens to the clock, right? The clock stops.
Mm-hmm.
And it's really important for patients that are either post arrest or they're trying to achieve ROSC, or even for VB patients that are acidotic, hypoxemic, hypercarbic. Time is important for these patients, and if you can stop the clock for them and provide adequate oxygenation and perfusion, that buys them more time. And also the other thing that happens during a timeout, right? The teams gather on the sidelines with their head coach, and they're planning. They're strategically planning. The game-winning touchdown, the game-winning field goal, the game-winning goal line stand, and that's what we do when we put a patient on ECMO. We're stopping the clock, and then we're giving ourselves or the healthcare team an opportunity to plan what is the next best intervention for this patient. I think you and we've both been in code situations where it can be pretty chaotic, pretty hectic. Communication can be lost at times, and thought process can also be kind of rushed, right? Because we're
Yeah.
under a certain amount of pressure. And so that's how I explain it to family members. It's really like calling a timeout. We're stopping the clock for their family member, and it's allowing us to critically think about what the next best intervention is for this patient.
Well, I think one of the things that it also does too is that oftentimes, as you know, different facilities are limited by what services they provide. So, and exactly what you do is you help transport these people from a place like mine that doesn't offer like transplants or things of that nature, or maybe even certain interventions, to another place with the pause button still on.
Exactly. Yeah. So we go out to a lot of facilities, some places that don't have access to ECMO at all. We place those patients on ECMO, hit the pause button for them, and transport them to a higher level of care or an ECMO receiving center.
So, to kind of go into, so this is pretty similar to being like on pump for cabbage, as far as a reference point for the cath lab beep. When it comes to like, why is this seemingly making such a huge break into the cath lab now? Like versus like this has been around. This isn't new technology. This has been for years. People have been on ECMO and especially on pump for surgeries, and this isn't new. But yet it's now like all of a sudden making a big splash. So why all of a sudden right now?
I think specifically for the cath lab, we saw an evolution in patient care specific to cath lab patients. So if you go back to, I believe it was September of 2008, there was a Senate bill passed, Senate Bill 891 or 891, and that was really the beginning of the elective PCI pilot program
Mm-hmm.
in the state of California. And they did the pilot program. And in May of 15, they passed another Senate Bill 906, which allowed eligible hospitals to apply and participate in the elective PCI program. And so what that did is it opened up the door for hospitals that had a cath lab but didn't have cardiothoracic surgery backup
Hmm.
to be able to perform elective PCIs. And currently in Northern California alone, we have 13 facilities that participate in this elective PCI program without cardiothoracic surgery backup. And I think these hospitals that are participating in it know that the only way to bridge these patients to a facility that has cardiothoracic surgery backup is through ECMO, right? So if a patient gets into trouble during a procedure, they can place the patient on ECMO and then transport them to a facility that does cardiothoracic surgery.
So do you think the expansion of like these large bore TAVRs and things of that nature with large bore access has really kind of changed how accepting facilities are and cath labs are of kind of going into ECMO? Because previously, 8 and 9 French was a big deal. Like I know years ago we started off with like 8 and 9 French guides, and that was every case, and then but there was groin complications, and we didn't have, the blood thinners that we have today. There was a lot of heparin and a lot of that going on back in the day. And that's why they started, that's why they were doing brachial cut downs and things like that back in the day, was to avoid that groin risk for the retroperitoneal bleeds. So now we're doing, core valves and Medtronic valves and Edwards valves with these big, big sheaths on these super calcified old ladies and old gentlemen. And you see that is why these physicians are more comfortable getting these huge cannulas in place now versus I think, even just a few years ago, we would have been hesitant.
Yeah, I totally agree. I think, interventional cardiologists are becoming more comfortable putting in, 20 French, 21 French, catheters in patients just because of these procedures like TAVRs and mitral valve replacements that we're doing percutaneously in the cath lab. I think this is becoming, part of their scope of practice to be able to insert these large bore cannulas into their patients.
Yeah, especially with, the advent of, previously this would have been done in conjunction with a surgeon, right? This is years ago. This would have kind of been like, with a surgeon, and now with you can watch the videos now on the internet. People are doing ECMO in the ER. They have
Right.
people going down to the ER to do it, which is crazy since some hospitals don't even float a swan. So so to start ECMO in the ER that's a huge jump to go from where we were with this is an OR procedure with a surgeon and a cut down, and these large sheaths. I mean, they're still large, but I mean, if I just did a TAVR on a 93-year-old the other day, and she was this itty bitty. I think she was 50 or less kilos for sure, and she was calcified in the whole nine. And we put a 16 dry seal in her, and she was fine. And we took it out and we perclosed it, and she was discharged the next day. So we're seeing that more, which takes it away from that surgical side of things, and well, at least for me, uncomplicates it to a large degree, for where I stand on the issue as far as like how complicated does it have to be, because surgery is kind of a complicated thing. Like there's no, unless you're in a trauma facility, there's just no real fast way to get to surgery. Like there's that big disconnect between you're going down in the ER, like part of the assessment process is, can this patient survive long enough to go through cabbage? Can they make it to being put on pump? And sometimes the answer is no. Versus the cath lab, I mean, we take people without a pulse and we bring them to the cath lab and see what we can do. And there's a much different transition time. We are there and we are bringing them up. So I see that as a huge difference in how ECMO is placed now. I mean, we haven't even done it yet, but I know that that's what our differences are. When I was meeting with, as we're starting a program, I was meeting with our opposites in the OR. They are like, who, that they were very surprised at how things are very different in the cath lab, and the level of transition that happens. Like, we show up and we go down and pick up the patient. There's not like, oh, was the anesthesiologist there? Was this, that? Like, there's a lot of steps for them to pick up a patient from the ER. And for us, it's just get them and go. So as part of that transition process, is that something you see that makes a difference with the availability of it? Like, just having like, okay, this patient's not doing well in ER, it's being used more frequently.
Yeah, I think the evolution, right, as you alluded to earlier, has typically been with a cardiothoracic surgeon in the OR suite, right? This is a surgical procedure done by a surgeon, and that has been the history of it. And I think we are starting to see the change where interventional cardiologists are actually and could be, you know, maybe better technically trained to insert these percutaneously, because that's what they do on a daily basis in the cath lab. They're inserting, some type of cannula guide wire percutaneously in the cath lab. And they have access to immediate imaging using fluoroscopy, which definitely increases safety and reduces complications for ECMO. But I think we are going to see a huge shift in the primary operators that can place ECMO and the location of where ECMO will be placed. And as you mentioned before, I mean, if you look at Paris in Europe, they're doing PCI or ECMO in the field. They're going
Yeah.
out and they're placing patients in the streets on ECMO, and I think that's pretty amazing.
Yeah, I mean, they do a lot of really forward-thinking things over there. Like, I think they're about 90% radial for their PCIs, and if you're doing radial PCI and you can slap ECMO in the groin, I mean, you don't ever stop working. You're just, you have two different sites, and if you had two different operators, you could be, you know, in and out in 20-25 minutes for everything. But like you said, the faster you get to that pause button, the faster you're at, the faster you're at a place of figuring out what the next step is. And that pause button thing is really a huge deal, because I think that we try and pretend like we're doing that with like other LVAD devices, like like the Impella and things like that. So like, um in your mind, where does it stack up with like the Impella, which I think is a great tool? I'm not talking crap about it, but just like, you know, if you're seeing somebody that's in these, that's not coding, but they're not doing well, I think a lot of people are like, well, why not just put them on Impella first?
Right. To be honest, there's not a lot of data out there, clinical data that shows a superiority of VA ECMO versus Impella. I did read a journal article. It was titled "Pro Veno Arterial ECMO Oxygenation." Veno arterial extracorporeal membrane oxygenation is superior to Impella for cardiogenic shock. It was an interesting article. It was two doctors out of the University of North Carolina, and they did present some interesting facts. But the one aspect of the article that really, in my mind, clearly showed superiority is the ability to oxygenate.
Mm-hmm.
Right. We know that the Impella is primarily for perfusion or offloading the left ventricle, but there's really no oxygenator component
Mm-hmm.
in the Impella device. And I think we see in the cath lab patients that go into shock or are in the acute phase of shock, cardiogenic shock. They do need that oxygenation support, right? It's one thing for perfusion, but they also need the ability to oxygenate or remove CO2 to prevent acidosis in these patients. And again, every case is different, but I think that the availability of ECMO being in your toolbox in your cath lab provides your physicians with a greater range of intervention and treatment. And so I think, if you have a balloon pump, you have Impella, and you also have ECMO access, I think your cath lab is providing probably one of the higher levels of care.
Yeah, I think we can. I think both parties, the Impella party and the ECMO party, both agree that there needs to be something there. They're just the balloon pump, as much as I love it, isn't enough, and there always needs to be that next level of whatever it is. And I'm just the more I research about it, the more I see it. It just we see cases all the time where somebody just can't make it to the next step for whatever reason. They just can't. Like you've had the 40-year-old with that's had a massive MI and he just doesn't have anything left. He's got, he's not just pressors aren't doing it, balloon pump's not going to do it, Impel's not going to do it, and he's out. He's viable for a transplant. He could get a transplant, and he could probably live a very healthy life. And I'm sure you have seen those cases where you've had, especially younger people, who have had a massive event, or they had an event so far out that the time to uh, uh, revascularization was so long that the heart muscle was just too permanently damaged. And especially in your rural areas, we used to get people helicoptered in from an hour to an hour and a half out by helicopter. I mean, God knows how long would it take them to drive them. But like in those scenarios, back in my earlier parts of my career, we would have loved to have something like that to put them on. But once they got to my facility, that was the end zone. Like there was no place else for them to go. And they just didn't have any heart muscle left. So they were just, by virtue of where they had their event, that was kind of their availability to medical resource at that time was what wrote their ticket. And now you have the ability to put the pause button on and really give people some options, and and kind of assess things and not make rush decisions about, especially involving neurological process and how that's going with the event, because that usually is affected when your heart stops.
Right, right. And I think there's been a lot of push from the American College of Cardiology and the American Heart Association. I think since 2006, they've really been working on designating STEMI and cardiac or resuscitation centers, just like you were talking about before. And I'm finding that these hospitals that are designated as STEMI and cardiac arrest resuscitation centers, they are seeing that really for those patients, ECMO is the only way to put the pause button on these patients and then get them to that higher level of care, bridge them to that next intervention.
Okay, all right. So I think we've got why it's great covered, because it's pretty great, and I'm actually pretty excited to start it myself. It's not as easy to
Yeah.
start one of these as you think. Uh, so what does the actual like procedure look like?
So in the cath lab, it's actually a fairly straightforward process, right? We're accessing the vessel, we're inserting the guide wire, and then it's basically a dilation up to maybe 21, 22 French on the venous side, so you can stick in a 25 French venous cannula. And then on the arterial side, maybe dilation up to 14 or 15 French to get a 16 or 17 French arterial return catheter in the left femoral vein. Sorry, left femoral artery. That would be it's pretty straightforward. The interventional cardiologists practice every day. When
Mhm.
they're doing heart caths and PCIs. I think the only difference is the larger cannulas. The larger cannulas. That's it.
Yeah, I definitely think it was, once I saw it, like I saw the videos and stuff of it being done in real time, I was actually really surprised at, like, it could be done, in that video I mentioned earlier in the ER, like it could be done in 90 seconds, like with somebody who knows what they're doing, or I think what we're talking about doing in our lab, until, obviously a portion of this is you got to have a place to send them before you turn it on, or else you're stuck with that patient. For other reasons we'll get into later. But what we're talking about doing is just putting an 8 French sheath in the artery and an 8 French sheath in the vein. And once we get all our ducks in a row, then we're gonna just switch them out over. I think we decided on supercore wires and upgrade them and sew them in, and it's just that simple. It's just that you just hook up. I mean, you don't put the venous sheath in until you're ready to hook up, but you can put the arterial sheath in and clamp it if you like. But the reality is, this isn't a big this is really isn't a big deal.
Right. And for us, when we go out, when ECMO PRN goes out, we've done, I would say, 60 to 70% of our cannulations actually at the bedside. So we're not in the OR, we're not in the cath lab, because again, you have to remember we go to hospitals that don't have cath labs, or they may not have 24/7, OR coverage. So we end up doing a lot of these procedures, ECMO implantation and initiation in the room in the ICU at the bedside.
So when you go out and do them, are you bringing a physician, or are you using somebody who's there to put them in?
So we have a different tiers of our ECMO to go service, and the top tier would be the entire team, which includes a cannulating physician, usually a cardiothoracic surgeon, our ECMO specialist, our critical care transport nurse, and two critical care transport EMTs. And that would be the top level of our ECMO to go service. And there's also times where there's a physician at the sending hospital who wants to place a patient on ECMO but does not have access to the equipment or supplies. And in those cases, we would send our team with the equipment, supplies, minus the physician, to go and assist the physician at the sending hospital on implantation and initiation of ECMO.
Okay,
Yeah.
okay, that makes a lot of sense. It sounds it sounds really good. Like, it sounds just, like, too easy. Like, why I mean, I know that everybody's starting these programs up. I mean, especially around us. I mean, we're doing it, and other places are doing it too. But, you know, this is a big city. We live in a big city area. Is this something you see scaling out to where I think it really needs to be is like you said, doing it basically, in the street, but in these rural communities that live out there, like do you see something like you're being able to scale up to kind of bring this level of service to these smaller communities that really would be impacted by it?
Yeah, they need something to support their patients until they can get the patient out to a higher level of care. And ECMO is really that tool that they can use for their patients, to support them, provide adequate oxygenation and perfusion until they can get them to that higher level of care. And it's going to make a big difference in those more rural areas for sure.
Yeah, so this being that you guys are mostly doing this bedside, do you see is it easier for you guys as like a business to see this initiated by like a cath lab situation where we're able to roll it out? Like in my lab, we're planning on putting the cannulas in and putting them on bypass with the perfusionist. Having the machine ready to go is our plan, and then bringing them to the ICU and kind of using you guys more as a transport service because there's nobody else will do it. Like it's got to be somebody who can run the machine. The perfusionist goes with, and an RN, critical care RN, and then your EMTs, right? Like there's just nobody else is really set up to kind of transport these people.
Yeah. We saw a need for this specific transport. I would say 5 or 6 years ago, when I was working as a nursing administrator in a hospital, and it was so difficult just to get a regular critical care transport ambulance to move an ICU patient. And then you throw on, some type of mechanical
Mhm.
circulatory support device like a balloon pump or Impella or ECMO. And then you quickly find out that there's nobody that can actually transport these patients independently. And it requires the hospital staff and equipment to go with that patient. And it opens up, a lot of different doors in terms of, uh, you know, financial responsibilities,
Mm-hmm.
liability,
Mm-hmm.
who's in charge of this patient during transport. There's a lot of gray area that can come up from these types of transports. And the reason why we started this was to really eliminate all of the questionable aspects of this high acuity transport and provide hospitals with a simple, straightforward transportation solution for their MCS patients.
Yeah, I think it's pretty awesome. I mean, it takes a lot. I mean, I envy you big time for being in the position you're in to kind of take it out there and start a new thing, and like you see a need and you filled it. And I mean, yeah, I wouldn't be blowing any smoke, but I mean, I really don't. My one of my questions on my little list here was like, "Are you hiring? Like, what does that look like?" I mean, like it's you can't talk about it. I mean, we're in Santa Clara, right? We're in the South San Francisco area pretty much, and this is just it's blowing up. I mean, you're on call. I see you all the time transporting patients. I mean, this has got to be, you know, a booming to growing industry that you've basically created by yourself.
Yeah, I'm definitely fortunate and lucky to have the foresight and put all of these aspects of this business together. And then again, opportunity, taking advantage of the opportunities that I've made along the way, being a nurse and my other medical history, medical experience. It's been definitely fortunate. I would say the first year of this business was definitely uncertain,
Mhm.
just because, and then again, it's probably with all businesses, but there's that kind of unknown that's out there, and it doesn't really reveal itself until you actually start, working and doing the business.
Yeah, and the other part of it too is it wasn't you need to make some noise. People need to know that you're there, and now that they know that you're there, they know you're there. I mean, it's I
Right.
mean, I don't know how many different places you're going to on a daily basis, but I know that I see you around a lot. So the word is obviously spreading, and we're in a fairly influential area here in San Francisco. Like, we're not, like a uh research center or, large influence kind of an area, but we're still pretty big, and people are hearing about it. And I know that when I started talking about this a little while ago, I had a friend of mine in New York who had been a traveler, and he was like, "Oh yeah, this is right now, this is the thing in New York because they're having a really hard time finding a way to, like you said, they can't transport them. So their only way to do this
Right.
in New York is to put them on a helicopter because you just can't transport them because they don't have the ambulances, they don't have
Right.
the time, they don't there's so many things that can go wrong, like the bridges can get backed up, the traffic is so much more. They have to put these people into helicopters, and so it's kind of like what you're doing, but add a whole nother level of ridiculous into it. So you just don't see it spreading there, but it's all everybody talks about it. So it's cool to see it
Right.
here and spreading. um so are you hiring, are you expanding, how's it looking?
Yes, we're definitely open to taking a look at new potential candidates. We just hired four new ECMO specialists to work on our team. They all of them have ICU experience, whether it be open heart surgery or
Mhm.
actual ECMO experience. Um, and I think most of them have some understanding of the transport aspect of it, but they really don't have a lot of critical care transport experience. So that is the other piece that we're trying to encourage some growth and help support them in that transition, because it's one thing to care for an ECMO patient in an ICU
Mhm.
setting where you have, resources available to you. You can call a physician, or sometimes a physician's in the unit. You can ask questions. You can call pharmacy. You can call for a stat X-ray. But once you take that patient that has the same acuity and you put them in a small, 6 by 10 box, and take away all those resources, then it becomes a much different picture in terms of patient care. And so that's one thing we're trying to help those nurses with.
Yeah, so kind of like I know you have a real different you had a different escalation in your medical history. So you were originally a an ECMO tech, right?
I actually, to go even before that, I actually worked on an ambulance out here in San Mateo County,
Okay.
um, and that's where I got 10 years of ambulance experience. Working on the different levels of care, and then I did transition into circulatory support while I was going to nursing school. And so that's where I really got exposed to all of the MCS devices and the OR and procedures like that.
Yeah, so what does that look like for somebody like I'm obviously a tech, not a nurse, which is, it is what it is. But like I'm super interested in those very like that niche kind of thing where you got exposed to, you know, uh just being that you were in nursing school, but you were in like kind of a tech role. You were like in a more of an assistive kind of a role, and it's changed. It's You've got a whole business centered around it now because of the exposure that you got back then. So if somebody was interested and wanted to kind of take a step further, how do you see these opportunities, and how does somebody find them? Like, where do you get the education, and like how do you insert yourself into something like this to kind of gain the experience, tech nurse or otherwise?
Yeah, I think, well, number one, if you're looking to get into perfusion here in the state of California, that could be slightly difficult, just because there are no perfusionist schools
Hmm.
in California. You would have to go to Texas or Arizona, somewhere out of state to get that training. But I think you can find some of the smaller hospitals are using perfusion technicians, whether it be for cell saving, for heart lung bypass cases. And I think there's an opportunity there just to get acclimated a little bit to that profession, and see if mechanical circulatory support is something you want to pursue. And I think the same thing for nursing. The ICU nurses, cath lab nurses, they have an opportunity to kind of specialize or learn more about MCS devices, whether it be through online education, going to conferences, or simply just volunteering to take call as a OR nurse or something, that can get them more exposure to MCS devices.
Yeah, I think it's because that's how I got into the cath lab, and that's why I like what you were saying so much is because you get a little insight into it, and now it's kind of come full circle for you. For me, it was I was in my X-ray school, and I was like, yeah, I'll check out the cath lab, and I had plenty of time, so I was there for a couple weeks, and I fell in love with it. Um, but in order to get into the cath lab, I ended up taking out the trash for a couple weeks at the place that I ended up getting a job at. Like I was working third shift and then taking out the trash and turning over rooms for free during the day just to kind of see it. Like I would get to watch cases. And I think there's a lot of times where people want to dip their toe in to see like, is this something I'm interested in without fully committing? And I think that like, like you're saying, like, watching some cases or, maybe taking on some patients or going down to the OR and kind of that technician style position, some people see it differently. I see it as like a stepping stone. Like when you can get into one of those positions, you never know which way it's going. And this obviously seems like, I won't say a sure thing, but I see the only thing happening with ECMO is it's just going to get smaller. Like it's not going to change radically. It's not going to turn into a different device. Everybody hops on a new device all the time, and there's just really not a place for us there. Like just in general, like
Right.
there's a place for the large industries to insert themselves, and then there's the support that they have with being a clinical specialist. But this is much more than that. This is very different. This is like actually using the tool the way it's intended, and then having a very different job. Like you don't have to be part of a hospital system uh, to use your experience, and that's kind of a whole another rant. But what you've done is really, really special, and I can't praise you enough because it's really special. You've taken something that you would only get paid to a certain tier in a hospital system for having this level of knowledge, and you've taken it out of a hospital system and you've owned it, and really taken a business with that. And I think that that's something that I'm trying to figure out how to do with the cath lab because it's not there. Like it's so intensive. But you would have thought ECMO would have been the same way. So I give you a huge props for that. I just can't imagine how to do it, but I'm glad you did it because it means it can be done.
Yeah, thanks, Jeremy. The one thing I always tell my nursing students is never turn down an opportunity, even if you think it's a bad opportunity or something that won't pan out for you. Never turn those opportunities down. Something will come of it, no matter what. So you just gotta keep on trucking through those opportunities, and one of those will pan out for you.
Yeah, and just kind of go where your heart is. I think is kind of the biggest thing. Is like if your heart's in this, and your heart is obviously in this, or else you wouldn't be putting in the hours that you are. But now you're putting in the hours, and you're getting paid for it. Like you're really getting you're in control, and that's huge. That's huge. While we're talking about getting paid for it, um, the big initiative, like how I think this is why I'm excited about it is because hospitals are the reimbursement in this, and this is pretty significant. And so that's why we're seeing the real buy-in from facilities. Like this isn't like, oh, it's just good for the patients and we should all do it. No, there's actual like reimbursement. There's money behind it. And when you see money behind something like this, you'll actually see adoption and integration. So what is the reimbursement behind it? What is the motivation for the hospital look like to kind of start these programs?
Well, I think it definitely starts with obviously the patient's insurance, right? Private pay is going to be paying more than Medicare. Medicare pays more than your Medi-Cal, and then obviously all of the above pay more than your uninsured.
Mhm.
But reimbursements, right? There's a few aspects of ECMO that get reimbursed. So there's the reimbursement for the placement of the cannulas.
Mhm.
There is the reimbursement for the initiation of ECMO, so initiation of the therapy. There are also reimbursements for daily management, and there are also reimbursements based upon the diagnostic or diagnosis related group, so the DRG. And before October of 2018, there was only one DRG, and that typically reimbursed at a rate of about 100,000 per case, so $100,000 per case. And what Medicare did after 2018 or October of 18 was they split up or they added 6 additional subsets of that DRG. And so central ECMO or ECMO that's placed in the OR with an open chest, that's your highest reimbursement, and that still stays just over 100,000 per case. And then what they did was they broke it down into 2 subsets here, which is peripheral VA ECMO and peripheral VV ECMO. And so for peripheral VA ECMO, there's 3 subsets under that DRG. And those are heart failure with shock, cardiac arrest, and VA ECMO plus a VAD, something like an Impella. So if you have ECMO and an Impella, there's a different reimbursement rate for that. And then the VV ECMO, again, there's 3 additional subsets under that. and it's vent support or ventilator support for 96 hours, sepsis with vent support, and VV ECMO again plus a VAD, something like an Impella. And so there's significant differences in reimbursement rates for those 6 DRGs, but that is how hospitals get reimbursed, not only for the procedure, but for the overall care of these types of patients.
So so it's safe to say that it's easier now for hospitals to start a program like we're starting or other hospitals are starting where you'll initiate it and you can get your reimbursement and then transport the patient. So you're not trying to slap together some kind of next level transport or transplant system or next level of care that you really don't have the adequate resources for. You can just put them on a pump, or in your situation, just contract you to do it, and then bring you in and you could offer that service versus what a lot of hospitals do, like with cath labs. When cath labs was new, they were just everybody wanted to have a cath lab, but they didn't have all of the other pieces to make it a successful cath lab. So this is one of those situations where you can literally kind of a la carte take this one piece, perform it, do it, and then if you want to escalate later you can, but you can actually just make money off of this and keep going at it, and it'll be a profitable item for you.
Exactly. If the hospital wants to, pursue this service line further as time progresses, they could start keeping these patients in house, and they can also collect for additional procedures and DRGs by having that patient remain with them in their organization after the implantation and initiation of ECMO.
Okay, and I did skip over one main question because we're kind of getting to the end of this, but well, I got two questions really. So we did kind of skip over when you went through the VV. What is the main difference what is the main difference between VA and VV ECMO? Venous to venous or venous to arterial ECMO?
Yeah, the easiest way I explain it is VV is for lung support, and VA or veno arterial is for both heart and lung support, right? So if the heart, the pump is not working, then you're going to look for VA ECMO. And if it's purely the lungs have an inability to oxygenate or gas exchange, but the heart is still functioning, then you're going to look for VV ECMO.
Yeah, so to follow up on that one, that was kind of leading you into a trap. With the big, the big word of the 2000s, which is the COVID patients. Are you seeing you're seeing the VV being used for them, but you transport them as well?
Yes, yeah. Since March of this year, our VV volume, I think, has definitely tripled in the number of patients we're putting on VV support for COVID, mainly for ARDS.
Hmm.
We have had, I believe, 2 cases during this pandemic that the patient was COVID positive, and the primary dysfunction or organ affected by the COVID was actually the heart. It was more of a viral
Hmm.
um,
Like an
viral
endocarditis.
case that. Exactly.
So how with all of this going on, how are you guys handling yourselves with, because this is VV? I mean, you see more COVID patients than I have. So, how did you guys handle yourselves with transporting these patients and being like right on top of them for the amount of time that you were?
Yeah, it's a lot of practice with your PPE, understanding the limits of your PPE, and following protocols to the T, because that not only protects you, it protects your coworkers, and obviously the next hospital that you bring that COVID positive patient to. But in my mind, as a nurse, I'm thinking, in terms of exposure to COVID, I would actually want to take care of a patient who's intubated, who's
Hmm.
got tubes and lines everywhere, because that's really decreasing my exposure
Sure.
uh, to the virus. In my mind, that's what I would be thinking.
Yeah, and I guess the last question I have, because I kind of skimmed over it earlier, when you're talking about initiating a new program, like we've talked about it, where you're just putting in venous and arterial cannula. How essential is it to have the central venous line and the Foley and the A line when you guys are doing? Is that something that when you guys roll up and you're top tier service, do you put all of that stuff in, or you expect some of it to be done, or how essential is it for you to transport them with any of it? Like, can you just go on the machine or?
It's definitely a case by case basis. Obviously, the more emergent cases where there's partial resuscitation going on, those are not our top priorities. We just want to get them on ECMO and support them, and all of the other ancillary type um, things can be done afterwards. But ideally, if we could have a central line in place, a Foley in place prior to the initiation or implantation of ECMO, that's obviously greatly appreciated. But again, there's times where we go to hospitals where they don't have 24/7 intensivist coverage. Some places have EICUs, and we can't have them put in a radial art line prior to our arrival, or even a central line prior to our arrival.
Yeah, and one of the other things I thought was really interesting that kind of came up when you were giving us an in-service. Well, now I got another question now. Uh, was your blood thinners? Like, I just assumed that these people would be on massive blood thinners, and when because we're not used to that. We're at cath lab. We'll do our inhibitors and so forth, or PTYK inhibitors and all and so forth, but we're not putting 10, 20,000 of heparin in an IV, and we were thinking that that's what was happening. So tell me about that.
Yeah, we found for at least for our practice that we give 5,000 unit bolus IV just prior to insertion of the cannulas, and that is adequate to prevent thrombus formation until we get the patient on ECMO. And you'll also find that there's some research going on showing that patients can actually go or be maintained on ECMO without a heparin drip. And I think we're finding that the technology of the components of an ECMO circuit are definitely contributing to that phenomenon, to be able to maintain a patient on ECMO without anticoagulation drips like a heparin drip. Because a lot of these cannulas are coated
Hmm.
with some type of synthetic material that prevents thrombus formation, as well as the oxygenators, and even all the way down to maybe a pump head can be coated with material that prevents thrombus formation.
Yeah, and
Uh, yeah,
yeah, I think that's super interesting because I think that was like a huge, like people were like, we're not heparinizing these people. Like, we're not set up for that. Like, they're going to bleed and we're not going to deal with it. Cath lab, we don't want that. We don't want those super, anticoagulated patients. So I thought that was super interesting. And then one of the other ones you brought up while we were doing our education, just kind of like as being a new person, kind of shocked me was you had talked about, oh, you got to increase your sedation because, it kind of gets filtered out, and when you're doing it for the first few times, like it's something that you don't think about very often.
yeah. I'll tell you, the first time I was managing an ECMO patient, the patient was completely calm, well sedated on propofol, some fentanyl, and I didn't even realize, back being a new nurse, the ECMO circuit actually absorbs all of those drugs through drug sequestration. And, as soon as you start ECMO, within maybe 5 to 10 minutes, the patient's just, sitting up wide awake, because all of those drugs that were keeping that patient, calm and sedated, have now been removed from the blood and are actually now absorbed into the ECMO circuit. So pharmacology or medication understanding of drug sequestration is really important in terms of nursing care. I always tell the nurses, be a little bit generous with your pain meds and your sedation.
Yeah, and while we're on that, because you came to our lab, and that's how we met, is because you were doing the education portion of it. So that is obviously a piece of your business, and your role is to do the education pieces. Um, Talk a little bit more about that. Like, how often are you doing these educations? Like, are you finding new labs that are, is it the chicken or the egg first? Or are people getting educated and then kind of coming to you to kind of start a program, or is it the program talk has already been initiated and then they want more education about it?
It's usually a case that sparks the conversation. So it's usually, some type of cardiogenic shock post arrest case that gets ECMO PRN into the door. And then they they want to be able to put the patient on ECMO. They want the service. They want to be able to transport these patients out. And it's kind of sad, but I think in most cases that we've been involved in, education and training has been the latter of those three elements. And we're really trying to go out there and promote education and training as number one, just so they can get a better understanding of what ECMO is, how it can be applied to patients, when it should be applied to patients, and how to safely transport these patients. So we do offer, education and training at individual hospitals, and we also have open, to the public training sessions throughout the Bay Area. But we have our most popular training session is with the nurses or respiratory therapists. It's an 8-hour day, 4 hours of didactic. And then the favorite part is the hands-on with actual working with devices,
Mhm.
troubleshooting, and we actually have a simulated cannulating dummy that we can let the students practice their cannulation techniques on. Not that they, as nurses or RTs, would ever cannulate anybody, but we find it's really important in the understanding for them to go through the procedure and understand what they're putting the patient through when they initiate and implant ECMO.
Yeah, I think that's huge, and that's obviously why we hit it off right off the bat, because I could tell your passion upon meeting on you that that was like a mainstay, and for me, that's huge too. Like, this is a big deal. Like, I know that this isn't really a big deal, but it is a big deal. The first few times you do anything that you've never seen before, like this is education. Having that preparedness going into it is a huge key. And just like you said, you wouldn't necessarily place the cannulas yourself, but we've all been standing next to somebody, a physician who's also nervous. And if you've at least
Mhm.
tried it once, you can be a little bit reassuring that, hey, yeah, I remember that too. Like two heads are better than one. And if you've at least done it once, even on a mannequin, it's better than never have done it at all and you have nothing to offer on that portion.
Yeah, it's like you're holding up the cue cards, for the physician's next move,
Yeah.
and that definitely reassures the physician, like, okay, I know this procedure, this is what we're doing, and I have a supportive staff who understands and knows the procedure as well. So that's important.
It's hugely important. It's one thing to have one person running the show, which physicians like to be, and that's fine. Like, it always helps to have a leader, but like it also helps to have a huge supportive cast. And if you don't educate them, they can't support you. So it's so different and refreshing to hear so much emphasis placed on education from somebody who's actually doing the service, because you would fare to make more money by not educating people and just doing it yourself and being like, I got it. But the reality is that the more you educate, the more people want, they're happy to see when I get our first patient, I will be happy to see you. Whether that's before or after the procedure, I will be happy to see you. So that, in my mind, it changes the dynamic when you have a resource. You have that resource. Like, I could call you and be like, "Hey, Jason, I'm stuck," and you'll answer it. And even though you're not, you know, on call for me or whatever, like, you'll still support the system. And I know that once we're getting rolling, we're going to be best friends because I'll call you all the time because we're going to be doing this all the time, hopefully. So I have already
I,
wasted way too much of your time, and I've definitely added on a lot to this. So What else? Do you have any other? I mean, how do people get a hold of you? Like, what do you want to throw your website, your contact information? What do you got?
Sure. Yeah. Anybody can visit our website. It's www.ecmoprn.com. We're also on most of the major social medias: LinkedIn, Twitter, Facebook, and Instagram. So you can definitely check us out, keep tabs on us, and see what we're doing in California. Yeah, if there's any other way you guys want to reach out, you can contact us directly through the website, and someone will either answer your questions or put you in touch with me, and hopefully we can connect and I can answer your questions directly.
Well, that's awesome, man. I appreciate your time. I'll put all your information in the different boxes that go around, so people can reach out if they have more questions. But again, thank you so much for your time. I really appreciate it. I'm so glad to hear your story. It gives me goosebumps and hope for the future someday uh, to have something similar. So thanks again, bud.
All right, Jeremy, thank you very much for having me on your show. Thank you.
Thank you once again to Jason for being on the podcast. I hugely appreciate your time. I'm just so grateful that we got to sit down and talk about ECMO and how it's coming to the cath lab. If you guys have any questions for Jason directly, reach out to him at ECMO, ECMOPRN.com, or on the Facebook, Twitter, or the other socials, or you can reach out to me and I'll redirect you to him. Just an amazing wealth of information. I'm so glad we could have him on the show. Thank you all for listening and let me know what you think.